Hey everybody, this is Rusty, and we are on part 4 of 4, Management of Cardiovascular Emergencies. Let's wrap it up. In this lesson, we're going to be talking about cardiac arrest, and that's the absence of ventricular contraction immediately resulting in systemic circulatory failure. Sudden death is defined as any death that occurs within 1 hour of onset of symptoms, and that can be chest pain, difficulty breathing. Risk factors for that sudden death is severe atherosclerotic or arteriosclerotic disease. You have shockable or non-shockable arrests. Here are some other causes of cardiac arrest. You can read them. Remember those electrolyte imbalances: sodium, potassium, calcium, magnesium, mother magnesium. If there's not enough mother influence, then there's going to be some trouble going on inside those cells. And then, of course, we're going to have to rule out reversible causes, and that is the H's and T's, and we'll jump into those next. Let's look at our 5 H's. Hypoxia. They are dead, so oxygen is not moving around the body, so we need to bolus them with as much oxygen as possible, 15 liters. Then slap that end-tidal CO2 continuous waveform capnography to monitor their hydrogen ions. Keep them warm. Keep them warm. They're not moving that warm blood around, so they're getting super cold, so cover them up, except for the parts you're actively working on. Hypovolemia, we need to start that line and let it go, because the blood is not moving around, and if it's not moving, it's going to start to coagulate, and then you'll have that disseminated intravascular coagulation, which leads to death. And then, if there is a waveform on your cardiac monitor, you're going to look for hyper or hypokalemia. And that's your H's: hypoxia, hydrogen ion, hypothermia, hypovolemia, and hyperkalemia. Next are the T's. We've got 2 in the heart: cardiac tamponade and coronary thrombosis. Remember the big 3 signs of cardiac tamponade: that is JVD, muffled heart tones, and narrowing pulse pressure. Then we have 2 in the lungs: pulmonary thrombosis and tension pneumothorax. Remember the big 3 signs and symptoms of tension pneumothorax: decreased or absent breath sounds, JVD, and hypotension. And then we have toxins. So as a review, we've got cardiac tamponade, coronary thrombosis, pulmonary thrombosis, tension pneumothorax, and toxins. The phases of cardiac arrest. Patients who suffer a cardiac arrest resulting in ventricular fibrillation go through several phases leading up to biological death. Those phases are electrical, circulatory, and metabolic. Pre-hospital interventions required depend on what phase they are in. Electrical phase of VFib begins at the time of cardiac arrest and ends approximately 3 to 4 minutes post-arrest. Adequate oxygen is in the myocardial cells already. Cells maintain that energy production and that aerobic metabolism for those first 3 to 4 minutes. Ischemia and infarction have not occurred quite yet. The only beneficial treatment is immediate defibrillation. So in that first 3 to 4 minutes, do high quality CPR at a compression to ventilation rate of 30 to 2. Get that monitor on them. Identify that shockable rhythm of VFib or pulseless VTAC, and don't delay. Shock right away. Get the pads on there. Set the monitor max setting. Clear your patient. Hit the defib button, and then immediately start CPR. Defib, defibrillate every 2 minutes while the patient is in a shockable rhythm. Circulatory phase of VFib is between 4 and 10 minutes post-arrest. Oxygen levels in the myocardial cells are inadequate. Anaerobic metabolism starts and lactic acid builds. Survival in this phase improves with at least 90 seconds of CPR prior to defib. 90 seconds of CPR prior to defib. Remember to defib every 2 minutes while they're in a shockable rhythm. And epi has shown beneficial in this phase. Epinephrine, 1 milligram every 3 to 5 minutes for the duration of the code. But if we're shocking every 2 minutes, why not give epi every 4 minutes? So every other shock, you're pushing a milligram epi. Sort of like a NASCAR pit stop, tuned for survival. The metabolic phase of VFib begins approximately 10 minutes post-arrest. Severe hypoxia, acidosis, ischemia, and infarct are occurring. Failure of the sodium-potassium pump happens. Sodium begins to diffuse into the cells, and water follows that sodium. Those cells swell and eventually lysis, or blow up like a water balloon. Major mechanism of cell death. The lysis is the major mechanism of cell death after the cardiac arrest. Current resuscitative measures do not improve survival during this phase. Here are the 3 phases of cardiac arrest in algorithm format. Remember, 0 to 4 minutes is the electrical phase. They need defibrillated quickly. 4 to 6 minutes is the circulatory phase. We need to circulate some blood for at least 90 seconds before defibrillation. And in the circulatory phase, we still have a good chance of survival. And then greater than 10 minutes is the metabolic death phase. We can do all kinds of things, but the chances of survival are unlikely. So remember the 3 phases: 0 to 4 minutes electrical, 4 to 10 minutes circulatory, and greater than 10 minutes metabolic death phase. Field assessment of that cardiac arrest. Hey, are you okay? You look, listen, and feel for that carotid pulse, any rise and fall of the chest, and any expiration on your cheek. And they don't have it. So you're going to start that high quality CPR, 30 compressions of 2 ventilations. Going to get that monitor on there and identify that arrest rhythm. Shockable VFib or pulseless VTAC, non-shockable asystole or PEA. You're going to attempt to get a history and see if there was any witnesses, and if any witnesses did CPR, and how long has the patient been down. Some cardiac terms to be familiar with. Resuscitation is the effort the providers give to save the patient. Return of spontaneous circulation is, he's alive! You got a rhythm and a pulse back in the field. And then survival, the patient walks out of the hospital. So just because you got a pulse back and a rhythm in the field doesn't mean he survived unless he walks out of the hospital. Cardiac arrest management. Hey, are you okay? There's no breathing, no pulse. You're going to start that high quality CPR, 30 compressions to 2 ventilations. You're going to get the monitor on there and identify shockable or non-shockable rhythms. And you're going to get your basic paramedic skills done. IVO2 monitor, just like the parrot. Get the advanced airway early. Get the advanced airway early. Get the advanced airway early. Because once you have that advanced airway in place, you can do continuous compressions and ventilate once every 6 seconds. Continuous compressions and ventilating once every 6 seconds will increase that chest compression fraction and lead to return of spontaneous circulation quicker. Remember to slap the cap and monitor that continuous waveform capnography. Some pharmacological considerations in cardiac arrest are epinephrine, 1 to 10,000, amiodarone, lidocaine, and magnesium. And remember to follow your medication with a bolus of fluid. Follow the medication with a bolus of fluid so it gets in the body so you can pump it around with that CPR. Withhold or stop resuscitative efforts. Stop or withhold if the patient has rigor mortis. They are stiff as a board. If they have a do not resuscitate order, or there's a threat to provider safety. Don't start or stop if that occurs. Other considerations to go ahead and try is if there's an overdose if they're hypothermic, and if you got ROS for just a little bit. If they got a heartbeat and a pulse, then it's not quite dead yet. So keep on trying. In hospital considerations, time of collapse to CPR, time of collapse to defib, what's the comorbidities, what's the pre-arrest state of the patient, the initial arrest rhythm, was it shockable or non-shockable, and the response to any resuscitation. So if their end tidal CO2 is less than 10 after 20 minutes, it means their cells aren't producing any waste anymore, and they're not going to survive. Inclusion criteria for terminating cardiac arrest resuscitative measures. The patient's over 18 years old. The cause is presumed cardiac in origin. Successful endotracheal intubation and ACLS standards have been applied throughout the cardiac arrest. On-scene effort has been greater than 25 minutes or 4 rounds of drug therapy, and ECG remains in asystole or agonal rhythms for that length of time. Termination exclusion criteria. You want to keep on trying. If the patient is less than 18 years old, if there are treatable causes, those H's and T's, there's a presence or recurring VFib or pulseless VTAC because the heart still has a little bit of electricity left in it. There's a transient return of a pulse, signs of neurologic viability. It was a witnessed arrest, or the family or others oppose the termination of resuscitation. Of course, you're going to always follow your local protocols related to termination of resuscitation. As a review, cardiac arrest, there are 4 arrest rhythms, 2 non-shockable, VFib and pulseless VTAC, and 2 non-shockable, PEA and asystole. Remember that sudden death is any death that occurs within 1 hour of the onset of signs and symptoms. Everybody's favorite slide, the end of part 4 of 4. I hope you enjoyed the presentation and the chat about cardiac arrest and cardiac arrest care, and have a great day. Stay alive.